Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. So we are at the 203rd episode of the CodeCast podcast. And to kick off September, I wanted to touch on the topic of auditing. And the reason is because I know a lot of CDI staff members, which is clinical documentation, either improvement or integrity, depending on which side of the, spectrum you're on that. A lot of staff listen to the CodeCast and have asked how they can address a physician that says only the physician should be making judgments on the medical necessity of documentation, not the auditing or coding staff, especially if they don't have a clinical background. So I wanted to discuss that a bit so you could respond in a way that will address the auditing process. And this is really a kind of a big deal because there's a lot of frustration out there when you look at the OIG model compliance guidance, or you look at what Medicare says as far as the physicians need to be at least 90% compliant in their documentation efforts. And then those of us as auditors, like myself, we go and audit the record. And then our conversations with physicians and individuals with respect to medical necessity, and how medical necessity, they say, is strictly a clinical determination, turns into kind of an argument and a little bit of a adversarial process. In these discussions, people are arguing that only a clinician should be able to make that assessment, and that it is outside of an auditor's responsibility or even capability sometimes to opine on such areas. Now, I've always taken the stance that medical necessity is really part of the audit. So medical necessity is not always about the service itself, but the documentation that justified the service. So a couple of examples are when the patient who goes to the provider for a sore throat and receives an EKG, and the patient who goes in for that same sore throat and a high-level office visit, let's say a 992 or 215, for example, that's what's billed. In the first example, the sore throat documents or documentation would clearly show that the medical necessity for the EKG isn't even there. Even if the EKG is well documented, which is usually what I get, it makes it part of the documentation of the audit. And so as an auditor, we can't make an assessment on that if the justification for a certain test isn't there. And so in another instance, it may not be that the office visit was not medically necessary, but what we're looking for was that level of service billed medically necessary? I was just completing an audit recently, and the codes that were in the level 4 and 5 range basically had medical decision-making consisting of lifestyle changes. Patient needs to now step up their walking efforts per week to 10 miles for some patients instead of 5. And one patient asked if they could go back to their running routine of at least 3 to 5 miles a week. And I'm seeing level 5 services billed. In no way is that a high-risk patient. Even in the presenting problems that were addressed, there were true chronic conditions, but there was no testing needed because the patient all the way through the record said, felt great, no problems. And then the doctor says, but I refilled prescriptions. I said, you basically said continue medication. So this is where, yes, there are some subjective judgments here, but if you had a formal audit and somebody is seeing an otherwise healthy patient get a refill prescription, maybe of their hypertension medication, that hasn't had any problem in the last couple of years, is out there running 5 miles a week and no complaints, no problems, you're going to have a hard time with that. And so medical necessity definitely is part of that audit, because CMS and also the Healthcare Compliance Association really look at that as far as guidance on how you audit a record, not just the tools we use to audit and what is there, basically the white paper information. But remember, in the CMS processing manual, the claims processing manual, medical necessity is still, and I'll quote, the overarching criterion for payment, in addition to the individual requirements of a CPT code. It would not be medically necessary or appropriate to bill a higher level of evaluation and management service when a lower level service is warranted. And then it talks about the volume of the documentation should not be the primary influence in which a specific level of service is billed, and documentation should support the level of service reported. So it's not that the provider rendered a service that was not necessary for the evaluation and management of the patient. It's that the documentation is failing to demonstrate, at times, the medical necessity for the level of service that's billed. So I agree that there could be clinical considerations as part of the type of treatment or service provided, but also there should be standard practice as part of a quality audit to review the entirety of the document and what I look for as an auditor. So when I say auditor as opposed to coder, this is somebody, and I include myself in this conversation, I'm looking at what we call a 360-degree view of the record, not just a snippet here and there of the record. So when a UPIC or a payer is conducting an audit, that audit will be for every word on every page provided. Okay, they don't just look at it what they call a myopic view or a single view of something. So when you look at what is being investigated by Medicare and all these audits that have restarted up, they're looking at everything that's included on that date of service. And so if something's included that wasn't warranted or didn't have medical necessity behind it, that's also part of the discussion. I had a record the other day where the patient came in. It was their yearly visit, I guess. It was a cardiology visit. And so they had 2+ chronic conditions, nothing exacerbated. Everything was stable. Okay, so now they're at moderate. As far as what was ordered, it was 2 screening services, which we don't count screening in problem-oriented visits in 2021. Don't forget that. So screening services did not count as far as the data points. There was nothing else that was reviewed or needed to be ordered because the patient was doing well, no complaints, no problems, nothing. And then in the assessment and plan of care, they ordered that's where I found where they ordered a nuclear and an echo and all these things. And I'm like, well, why? Even in the addressed problems, didn't require the ordering of a nuclear. It didn't even say this is a 6-month recheck because the patient has ischemic heart disease. So again, when we're looking for medical necessity of the record, not just what was done, but did you prove what you did and why it was done? That's what we're looking for from an auditing perspective. So when you audit for medical records, it's to see if you can support the level of service. But we look at that 360 view and we say, okay, can we support the entire record, even what's being ordered, what's being asked to be tested, even, anything that is coming out of that? And are they supporting the need for some of those tests? And I would say 9 times out of 10, unfortunately, when I get a request for a formal audit from a payer, it doesn't support it. Now, one of the things I strongly recommend in practices, and this is being proactive, is to do internal and external audits. So I have a lot of clients that they have me do this every year. I have several clients in particular that we audit them every month, and we go on rotation for physicians. It just gives you peace of mind, because if you would ever get formally audited, you can go, well, we actually have an external auditor that, or if you do it internally, whatever you have the staffing for, that has actually looked at our records and reviewed them and has, said that we're doing fine or has approved what we are submitting to the payer. So just wanted to kind of clarify that, because I think sometimes a lot of that gets lost when the physicians say, well, I have 2 chronic conditions and I wrote a script, so immediately that's a level 4. Not necessarily. Just because you write a script or, fulfill a prescription or say continue medication, that's not always enough to make sure that you have supported the medical necessity of the claim in addition to the components of the E&M guidelines. Another issue that came up in something I was reviewing the other day was a patient that actually they were stable, but they did have one of their chronic conditions worsening. So it wasn't a severe exacerbation, so we're still in the level 4 moderate level. But it doesn't show how the exacerbation was going to be treated. All it said in the plan of care was lifestyle changes, green leafy vegetables, and not add salt to your diet. So that's not a high-risk plan, and the doctor billed a level 5 service. So when you're very general in some of that information, it's really, really hard to support that level. When I see things like chronic conditions managed by the primary care doctor, managed by PCP, that's also not going to get you a level of service that you're reporting if you are not addressing those problems. And again, we still have those on-demand webinars if you need to get a retake on and a reminder on how to report some of your 2021 E&M services. We're also going to have a mid-year checkup on that too, so make sure you take a look at my website on the updated schedule. Another thing that's come up recently, and I'm going to switch gears a little bit, is I'm starting to see people getting very lax with telehealth visits. So I'm seeing office visits being billed again when the video portion isn't there. I'm not seeing the language when there is an audio and video visit, I'm not seeing the language that reflects what platform you use, that the patient may not be protected by HIPAA if it's Skype or if it is FaceTime, if it's something that's not your EMR. And also I'm seeing some of these being billed as time-based visits and you're not meeting the time level. I had one in particular that tried to bill a telehealth audio-only visit at 20 minutes and try to submit a 99213. And I was like, what are you doing? You guys know better than this. So you have to be very, very careful with that. And that leads into my question today. That is a coding question that I got from a listener. And it says, Terry, our dietitian wants to start calling patients for health and wellness under the phone call codes 98970, 98972, since during the public health emergency, it's allowed under the CARES Act. Can we go ahead and run her a list? We just wanted to run it by you first. Oh boy. Okay, so first of all, again, let's get back to medical necessity. I'm going to sound like a broken record today. First of all, you can't bill anything that isn't medically indicated, and also that isn't within the rules for coverages. Remember that. It's not just now, it's those codes are covered for non-physician providers, certain ones that are qualified. Those codes are only covered under the public health emergency as it relates to COVID, remember. Now, the patient doesn't have to have COVID or test for COVID, but these are patients that otherwise would have come in the office for services that were covered. So if you have a dietitian or you have somebody that is able to discuss information about medical nutrition for the patient, they're a patient that had, they were a kidney patient or they're a diabetic patient. And so these are not patients, insulin-dependent diabetes too. These are not patients that you can run a list on any patient in your practice and say, hey, how's your diet going? Just because these codes are reimbursed, for that provider, but in certain circumstances. So you have to make sure you understand when, and I would look up, not just, and I mentioned medical nutritional therapy a couple weeks ago, but also look up when a dietitian can provide services and under Medicare and what are the guidelines. So again, you're looking at diabetic, insulin-dependent patients, you're looking at patients who had kidney surgery or had a kidney removed, kidney transplant, I couldn't remember the name, kidney transplant surgery. There are some commercial plans are allowing it pre-bariatric patients, and most are not. So it's really something that you have to ask before you do it. So please do not start that list and start calling any patient you think, even if they could benefit from it, it's not a payable service. So just be cautioned by that. I'm seeing a lot of everyone saying, oh, now we can do whatever we want. I'm like, no, you can't. Please be careful by that. Our coding question today is brought to you by CeraVe. Daily moisturizing lotion for normal to dry skin, developed by dermatologist, moisturizes and helps restore the protective skin barrier. CeraVe. So I'm going to end today with my personal tidbit, and I know I'm doing kind of a shorter version today. I'm actually moving today, so this is one of mine. I got to get my podcast done because I'm moving and my movers come here in about an hour. But my personal tidbit this week, and it is kind of a sad tidbit, our thoughts and prayers really go out to the 13 military soldiers who lost their lives in Afghanistan this last week fighting for our freedom. So our hearts are with your families, and I can't even imagine what you're dealing with since we know many of these military men were, under 25. So we definitely sympathize with what you're feeling right now. Also, those recovering from or trying to recover recover from the Hurricane Ida's destruction in the Louisiana area. We also extend our prayers that you and your family were able to find a safe place during this time, and that hopefully the recovery will be quick. If anyone has the means out there to find a shelter there to donate to, please make the effort. I know we've done that, and we just want to make sure that we can all be kind of together in when we have these acts of nature that cause this destruction. Okay, everyone, until next week, that's it for me. Make it a great day, and I'll talk to you next week on the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.